Welcome to the 2020 CGA-IGC podcast series, brought to you by the Education Committee. This season, we'll be hosting a virtual journal club. Each episode will highlight a recently published journal article that is important to the field of GI cancer genetics and will feature an interview with one of the article's authors. Keep listening to find out more about this episode's host, guest, and featured article.
My name is Dr. Swati Patel. I'm a gastroenterologist at the University of Colorado Anschutz Medical Center, and I'll be hosting today's podcast where we will learn about the latest and greatest in the evaluation and management of patients with serrated polyposis syndrome, or SPS. The focus of our discussion today will be to review the recently updated World Health Organization guidelines on the diagnosis of SPS and highlight recent publications that shed light on a personalized approach to surveillance in SPS and long-term outcomes in natural disease course in those with SPS undergoing colonoscopic surveillance. I have the distinct honor of introducing our expert guests, Dr. Arne Bleinberg, who is a research fellow at Amsterdam University Medical Center, and Dr. Evelyn Dekker, professor in the Department of Gastroenterology and Hepatology and Gastrointestinal Oncology, as well as the head of the Hereditary Cancer Center at the Amsterdam University Medical Center. We are delighted to have these world-renowned experts in serrated polyposis. Dr. Bleinberg, Dr. Dekker, thank you so much for being with us today.
Pleasure. Thanks for inviting us.
So let's dive right in. From your perspective, how would you describe SPS? What exactly is it? How common is it?
Yes, I will start off with explaining what it's like. Well, it's a poorly understood colonic syndrome characterized by multiple serrated polyps spread throughout the colon and the rectum. Based on the new guidelines, we can characterize two different types, which is either the type with several relatively large serrated polyps in the right-sided colon, or the type with many, at least 20 polyps throughout the colon. So we are counting the number of serrated polyps, but usually it can also coincide with regular adenomas. It requires lifelong colonoscopic surveillance as those patients have a high risk for colorectal cancer.
And talking about those risks, how common is SPS and what exactly are the cancer risks associated with SPS?
I think the first one, how common is it, is already quite an interesting question because it is probably much more common than many people think. Based on some recent studies, we found actually that 1 in 238 patients undergoing a primary screening colonoscopy will eventually fulfill the diagnostic criteria of serrated polyposis syndrome. And then our Spanish colleagues, they showed that if you only take FIT positive colonoscopies, it's almost 1% of those patients will eventually fulfill the diagnostic criteria. Now that makes us wonder why many physicians still think it's such a rare disease, because this makes it by far the most common polyposis syndrome. But that's probably because there is a huge underdiagnosis of serrated polyposis syndrome, which is, well, that's what we think anyway, might be a result of the fact that physicians might not always apply the diagnostic criteria of serrated polyposis syndrome. Because you have to be aware of these criteria, and also it requires a physician to count the number of serrated polyps a patient will develop throughout his or her life. And that's time consuming, especially if the colonoscopies have been carried out in different centers. So you really have to retrieve the information to make the diagnosis. And that's a pity because your other question is how often do these patients develop cancer? And actually, if you correctly diagnose SPS and you provide the proper treatment and surveillance, the risk of cancer is actually really not so large. It's rather small. But if we look at the whole group of SPS patients, then still 15 to 35% based on retrospective studies will have a past history of colorectal cancer. Now that's quite high. But the overwhelming majority of those cancers have been diagnosed prior to them being diagnosed with SPS or at the time of diagnosis of SPS. So if a patient with SPS has a history of cancer, it is most likely that that cancer was diagnosed when it was also discovered that this patient has SPS or before it was discovered that he or she has SPS. Because if we can correctly diagnose the syndrome and then remove all the polyps and provide frequent, so yearly or every 2-year endoscopic surveillance, the risk of cancer becomes quite comparable to the risk you see in the general population.
But Arnie, you forget to mention that indeed one should count the number of serrated polyps throughout a person's life. So indeed not at just one endoscopy, but several. But also it requires an endoscopist aware of serrated polyps.
Yes.
And now that we have high definition equipment available and patients are prepping better and better and doctors are aware of their presence, they might find them, but they're usually quite difficult to see. Much more difficult than adenomas because their color is nearly the same as the surrounding tissue. They might have a flat appearance or just slightly elevated. So you also have to have an eye for it and you have to know what to look for, both in the diagnosis as well as once keeping those patients under surveillance. It just costs some extra interest and time.
Yeah, definitely.
So it sounds like a very common condition, unfortunately grossly under-recognized, but providing with a great opportunity because though there's a high risk of cancer associated with this condition, there are highly effective interventions, colonoscopic surveillance, as you mentioned. Are there other cancers that we should worry about, extracolonic cancers that have been reported, SPS patients?
As far as we know now, no. There has been one report showing a slightly increased incidence of pancreatic cancers. However, in our cohort, we looked at this very well, and we did not find any other cancers associated with this syndrome.
Great. So at the moment, we focus on the colon.
Yes.
Yeah.
Can you talk about what we know about what causes SPS? Do we have an understanding of the etiology?
No. Mostly not. So there is a very small group that has a mutation, the RNF43, but this appears to be a very, very small group, probably mostly consisting of those people with several members in the family having the same type of polyposis in their colon. So it seems to be a really different, outstanding little group. Otherwise, there's clearly a relationship with smoking. Amongst our cohort, we have a high percentage of smokers, somewhere between 57 and 75%. And many patients do have first-degree family members with colorectal cancer, about 30%, but with the clear picture of serrated polyposis syndrome, less than 5%. And actually, that high number of first-degree relatives with colorectal cancer might have to do strongly with ascertainment bias, because those patients were the most severe ones, dragging also their family into the endoscopy suites. So no, it's probably more than just one syndrome, I think. And it probably has several different causes.
Yeah, I think especially the last thing you say is really important, which makes it so difficult for researchers to study the etiology of SPS, because there's one name for a couple of different types of phenotypes, which each might have their own etiology. So if you study the etiology of SPS, you need large cohorts to be adequately powered to perform subgroup analysis, because otherwise you put different diseases in one bucket and then you try to solve the etiology, and that's really difficult.
Right, it makes risk factor analysis very challenging. You mentioned smoking as a potential risk factor. Are there other environmental risk factors that have been looked at with relation to SPS?
As far as I'm aware, there haven't been other established risk factors other than family occurrence and smoking behavior. There was recently a systematic review on the risk factors for sporadic serrated polyps, and then there were some other less clear relations, for example, with dietary patterns or alcohol consumption or overweight. But as far as we know, there haven't been other established risk factors for SPS. Sorry, I do forget to mention that a history of radiation might cause serrated polyposis syndrome.
Yeah, but we're not so sure if that's just the serrated polyposis syndrome or a more heterogeneous type of polyposis syndrome, also including many adenomas.
Yes, exactly. Yeah, we have a couple of those ourselves too, and they have a really severe phenotype actually.
So evolving story, unclear if overlapping
with
adenomatous polyps. Very, very interesting. So as you're aware, and Dr. Decker, you're a co-author on the 2019 World Health Organization guidelines. They were just published last year. Can you talk about the updates in the WHO criteria compared to the 2010 guidelines?
Yes, definitely. But Arne prepared this slide, so I think he should do it.
Right. Well, I have to do it too. So Evelien was part of the working group that created the guideline, but we also wrote a review together recently discussing the different changes. And I think to start with, the present criteria, they include two different criteria actually. So the first being 5 or more serrated lesions. So that can be hyperplastic polyps, sessile serrated lesions, or traditional serrated adenomas, located proximal to the rectum, all being at least 5 millimeters in size, with 2 being more than 1 centimeter. So that's the first phenotype. And the second one is more than 20 serrated lesions, so all 3 subtypes, spread throughout the colon, with at least 5 located proximal to the rectum. So those are the new criteria, and they are actually almost identical to the 2010 criteria. But there are some slight changes. I'll start with discussing the most major changes in the criteria I just discussed. So now the polyps have to be located proximal to the rectum. This used to be proximal to the sigmoid colon in the previous criteria. And one of the main reasons that the working group decided that they should broaden this criterion to also have sigmoid polyps be included in the diagnosis is because about 50% of the cancers in these patients occurs in the distal colon, so in the rectus sigmoid. So even patients with a really distal phenotype might have a significant risk of cancer development. So that's an important one. And the most eye-catching difference probably is that the previous criteria had 3 different criteria and the new ones only have 2. So one criterion has been abandoned altogether. And I'll quickly mention that one. So in 2010, the criteria also included that any number of serrated lesions proximal to the sigmoid colon in a patient with a first-degree relative with SPS should be diagnosed with SPS him or herself. So that means if you have a hyperplastic polyp, regardless of size, in your descending colon, and you have a first-degree relative member with SPS, you should undergo the same treatment and surveillance, which is very strict, as the patients with a really strong phenotype. And the working group and many experts with them decided that the criteria were not stringent enough. So too many people would fulfill this criterion if you would really apply it.
And it seemed that the updated guidelines de-emphasized diminutive serrated polyps as well. Can you talk about the decision-making behind really emphasizing that the criteria should include 5 millimeter or greater polyps rather than these very, very small polyps?
So what you mean is that the hyperplastic polyps smaller than 5 millimeters are now not counted towards the diagnosis anymore, right?
Correct.
Yeah. Well, the main reason is probably that we're continuously trying to find ways to make the criteria just stringent enough. So they shouldn't be too loose. So with improved awareness of endoscopists, improved quality of equipment, better endoscopes, NBI, BLI, you name it, we find more and more polyps. And actually the number of patients with these really tiny hyperplastic polyps in their distal colon, which might not be so relevant, we are reluctant to diagnose them with SPS and expose them to the frequent colonoscopies because that imposes them maybe to more danger than the tiny hyperplastic polyps.
Yeah, but what I think should be stressed more is that what we try to make clear is that we don't want those polyps only in that area. So just having 20 polyps in the rectum is not enough, even if they're 5 millimeter or larger, but there should also be right-sided polyps. And in the past it said spread throughout the colon, but nobody knew how many were allowed in the distal colon only. So that's why we try to make that a little bit more clear.
Fantastic. I think the new updated guidelines are very clear and very helpful, and I think are a very important step towards improving recognition of SPS. The follow-up for patients who are diagnosed with SPS and you care for a large cohort at your center, can you talk about what your group has learned regarding the approach to endoscopic surveillance, in particular the publication in gastrointestinal endoscopy and in gut talking about personalized surveillance programs?
So, well, I think what comes first really is what we discussed already a little bit previously, is that the endoscopist should have an interest in high quality colonoscopy and have the knowledge of what those serrated polyps look like. So I think that's where it all starts. So the quality should be perfect or nearly perfect. The endoscopy should be in the whole colon, so introduction in the cecum. The quality of the bowel prep should be very good, and high-end equipment should be used. And then any serrated polyp detected, any relevant serrated polyp, which is probably anything above the rectum or larger than 5 millimeter in the rectum if it looks hyperplastic only. Any other adenoma or SSL should be removed, all of them at that endoscopy. So first what we do is, once we get those patients reversed, we try to clear the colon of all relevant polyps. Also relatively quick, because we regularly run into patients already have small cancers in situ, because if other doctors might not be aware so much of the syndrome and the risk, they might not look as well at all the different polyps, and they just might miss early cancers in that patient. So at least we want to schedule that first referral endoscopy relatively quickly, then clean the colon. And it might be necessary to perform 2, 3, even 4 colonoscopies, taking out up to 100 polyps, doing large EMRs even, before that clearing stage is met. After that, we go to the surveillance schedule, and that indeed we have made more personalized. And I think Arne is going to explain it, are you?
Yeah, well, why not? So what we have implemented here in the AMC is that we had the feeling that providing all our patients with yearly colonoscopies would impose a lot of colonoscopies that were not always necessary, because often we didn't really find any relevant lesions during surveillance colonoscopy. So we've tried to extend the surveillance intervals for patients whom we thought had a low risk of colorectal cancer. So what we do here in the AMC, and that's the gut article that you are referring to, is that after each surveillance endoscopy, we look whether a patient has a high polyp burden. So that means advanced adenomas or advanced serrated lesions. If so, then the patient comes back after 1 year. Also, if 5 or more relevant lesions are detected at one colonoscopy, we refer them back after a year. But if none of those are found, we have extended the surveillance interval to 2 years. And that turned out to be really safe. And even so safe that the patients that we thought would be eligible for the 2-year interval had a much lower rate of advanced neoplasia upon follow-up than the ones that we referred after a year. So it might even be that we can further extend that to maybe 3 years, for example. So that way we are trying to reduce colonoscopy burden based on personalized characteristics.
That's a wonderful service for these patients, because clinically, those of us who care for these patients certainly appreciate that there's a widely variable phenotype. And, really these personalized approaches allow us to customize surveillance based on that phenotype. So that data is very, very important paper to really get out there. Can you talk about the long-term outcomes that you've seen in your cohort of SPS patients that are undergoing surveillance? At the beginning of our conversation, you talked about really this wonderful opportunity we have with colonoscopy to mitigate and really decrease the cancer risk in these patients. This recent publication in GIE really described the effectiveness of colonoscopic screening in decreasing cancer risk in your patients. Can you tell us a little bit about that paper and what you've learned about the impacts on cancer risk and really the impacts of doing such frequent colonoscopy?
So we had the opportunity in the AMC. Well, I have been only around for 4 years here, so I haven't been at this very start of the follow-up. But 10 years ago, or already 12 years ago, my predecessors, they started following all our SPS patients in a prospective cohort. And we've continued doing so until last year, when we ran analysis with all the surveillance data that we had available. Because we were really interested, if you take one center that has provided dedicated care on a dedicated hereditary outpatient clinic with specialized endoscopists, how far can you go with cancer reduction in these patients? So what we found was actually that the risk of these patients developing cancer while they were under surveillance was really low. We only had one patient that, after being completely cleared, still developed cancer during our surveillance. So that yielded a 5-year cumulative incidence of only 1%. That's quite low. And we were also interested whether this comes at the cost of endoscopy-related complications, because this cancer reduction, of course, is achieved by performing many, many colonoscopies. But we also found that surveillance was actually quite safe, with a post-polypectomy bleeding rate of only 0.45%. So we were quite satisfied with that, actually. But there's one side note that I think that should be noted with this study is that we specifically looked at the outcomes during surveillance. Because if a patient is referred to our center with 20 or 50 very large serrated polyps in the cecum and over the appendix and other difficult places, then to get all those polyps out, the risk of perforations might be a multitude higher than during the surveillance.
Yeah, but things have really changed, because what is nice about this paper is that indeed I started about 10 to 12 years ago with the first research fellow, and indeed RNA is the fourth, and the fifth one already started now as well. Each one is the other successor. And in the beginning, we were still operating quite a lot of patients when having numerous large serrated polyps. And now the bar for patients to be operated is for us really high. We really discuss all the potential benefits of an endoscopic clearing, if achievable, if the patient is motivated. But this is really quite different from the past. And indeed, that comes with some complications when performing, 4 or 5 clearing endoscopies, taking out 100 polyps, many of them piecemeal. But yeah, we have changed our practice, and I hope we still will. I hope to be able to provide those patients with better patient care by time.
That's wonderful. And if you could just take a moment to talk about your endoscopic approach. You mentioned clearing many, many polyps, oftentimes piecemeal, and that your practice has evolved over the last 10 years. In terms of the patient who presents to your endoscopy suite today, what is your approach from optical diagnosis all the way through to resection to removing these polyps?
Well, as I said, the first thing we do if we get such a new patient referred, we schedule the first endoscopy relatively quickly, because we know early cancers might have been missed when being overwhelmed by the sight of all those polyps. So what we do is always teach my fellows that the only exception for inspecting a colon is a polyposis patient, either SPS or any other one, because already on your way in, you try to make an estimation of the burden of polyps and whether it's going to be at all possible to treat the patient endoscopically instead of by surgical resection. So on the way in, I want to be in the room already, and we look together at the number. You won't see them all, but just to get a slight idea. And then generally, if we agreed on the outpatient clinic before we do the endoscopy that we would try to head for endoscopic clearing, we will start in the cecum by detecting all polyps and making an optical diagnosis, because that, of course, makes your strategy. Because if it's an early cancer, strategy might definitely be different than if it looks like a really benign polyp. And we take usually for the first endoscopy about an hour and a half, as long as the patient is comfortable. And after that, we discuss. And again, if we aim to do that endoscopically, we might need 2, 3, 4 times before we are able to clear the colon. If the burden is really too much, or if the polyps are way too difficult, or indeed run into the ileocecal valve or in the appendicular orifice, which might make clearing impossible, we don't do that. We don't start removing the polyps. But what we would do then is pull back the endoscope and make an estimation whereabouts we would like the surgeon to take the colon out. So usually what we then is our aim is to try to keep the rectosigmoid approximately about 30 centimeters from the anal verge. And what we will do then is remove all the relevant polyps distal from that and put tattoos for the surgeon, so he knows exactly from what area the colon is safe to be left in. So we do try to do that decision making in the endoscopy suite for either going endoscopic clearing or surgery. If it's a really difficult decision, we make many images and movies and take back and sit down and discuss amongst experts, and then discuss with the patient the several options and do the decision making with the patient.
And for those patients in whom you recommend surgical resection, it sounds like a more extended resection to address the majority of the polyp burden is the surgery of choice. What is your surveillance program postoperatively? Is it similar to patients with their native colon?
Well, you can tell that, Arne. It's your topic.
Yeah, so we always perform a colonoscopy within a year after surgery. That will be the first surveillance. But then what we found, actually, we did look specifically at our patients that had a history of subtotal colectomy. So they only have the rectum or sigmoid in situ. And we found that their risk of developing advanced neoplasia is extremely low. Actually, in a recent paper that we published, we suggest that if you do not find upon the first surveillance colonoscopy any advanced neoplasia, and 3 years later you do not find it again, then you might even be able to extend the surveillance intervals to 5 years. But this is not general practice yet, so we don't advise that people start doing this in their practice, but we think that this should be a topic of study, because we found that these patients have a really low risk of developing advanced neoplasia and probably an even lower risk of developing cancer.
Thank you. And speaking of topics of additional research or unanswered questions, what do you see as the top kind of high yield next steps in your work, top unanswered questions about SPS?
Many questions that still remain. So I think an interesting one is still about the etiology. So what is the role of the smoking? And especially, does smoking cessation really, can it stop polyp development? We've had some very interesting patients. We have that experience, but that's not systematically yet proven. Then maybe it looks like there's groups that stop having new polyps, which might depend on the quality of the colonoscopy on beforehand, because I'm not a believer in that those patients recur so quickly in having large serrated polyps. So I think usually those were missed the endoscopies before, but once under good control, endoscopic control and surveillance, there's quite a large group of patients that won't have quick recurrences. So what's the difference between those and those patients that do need frequent endoscopy? And then I think Arne can talk a little bit about his lab work.
Yeah, but just to add to your final one, so we've shown that we are starting to reach the ceiling as how far we can go with cancer prevention. But I think in the future now we're trying to see how far we can go with surveillance interval extension. Yeah. So, but yeah, definitely. So I'm also very interested, of course, in the molecular background of Serrated polyposis syndrome, because there does seem to be a familial occurrence, but whole exome sequencing studies have shown RNF43 to be related, but otherwise no germline mutations have been shown. So I think it would be really interesting to dive into the epigenetic hereditary environment of the colon, because, well, from previous study, there seem to be aberrant methylation patterns in the colons of SPS patients in a healthy colon. So we might have to go from genetic to epigenetic etiology. And what's also really interesting is that the so-called dangerous serrated polyps, the large sessile serrated lesions, occur mainly in the proximal colon. But about 50% of all the cancers that develop in SPS patients is located in the distal colon, which makes you think maybe adenomas play a more important role in cancer development than we think now. And well, our group has published one study in 2010, but that was rather small. So I think it would be really interesting to look at large cohorts of cancer samples of SPS patients to see whether they develop via the adenomatous pathway or the serrated pathway, because this could be surprisingly often the adenomatous pathway. Yeah, I think those are the most interesting topics for future research. That's what we are going to focus on anyway.
And we are interested in research in terms of teaching others how to recognize serrated polyps definitely. And remove them adequately. So you can call that research. It's also improvement of practice, but we think there's still quite a lot of work to do there as well. So we are developing a validated e-learning system on learning those issues in serrated polyps and the syndrome.
So it sounds like many areas with a lot of work to be done. It's very exciting to hear about. I do want to thank you both, Dr. Bleinberg, Dr. Decker, for your time today. This has been an incredibly high-yield review of SPS diagnosis and management. To our audience, please be sure to review the 2019 WHO guidelines that Dr. Decker has co-authored, published in the journal Histopathology, as well as the papers we discussed today, authored by both Dr. Bleinberg and Dr. Decker, published in Gut and Gastrointestinal Endoscopy. We will make sure to post the citations in our podcast descriptor. To all, stay tuned. Our next CGA podcast, as always, we'll be reviewing the latest and greatest in hereditary and sometimes not hereditary GI cancers. Thank you so much for your attention.